What is the appropriate next step when a young patient arrives to the emergency department with ongoing CPR, achieves ROSC after more than 30 minutes, and is found to have an acute STEMI? At first glance, this may appear to be a straightforward question, yet in real practice it is anything but simple. The case I recently encountered illustrates the complexity. A 32-year-old man was brought to the emergency department with ongoing CPR performed by ambulance personnel. His cardiac arrest was witnessed, but no bystander CPR was provided. Resuscitation was continued in the ED, and ROSC was eventually achieved. His initial reported rhythm was ventricular fibrillation. The total CPR duration exceeded 30 minutes. Post-ROSC ECG demonstrated acute anterior ST elevation myocardial infarction. The patient was admitted to the ICU under intensivist care. On arrival to ICU, his blood pressure was stable. A cardiologist evaluated him in the ED and opted not to take him for immediate angiography. After ICU admission, the intensivist again requested urgent coronary angiography with possible primary PCI. The cardiologist declined, citing the prolonged duration of CPR and the low anticipated chance of meaningful neurologic recovery. Unfortunately, the patient progressed to brain death several days later. Was the cardiologist's initial decision justified? Current international guidelines, including the 2023 to 2024 AHA, ESC, and ERC recommendations, consistently emphasize ST segment elevation after ROSC is Class 1 indication for immediate coronary angiography and PCI. Regardless of arrest duration, pre-hospital CPR quality, and initial neurological assessment, neurologic prognosis is not reliable immediately after ROSC. Prognostication is recommended greater than or equal to 72 hours after targeted temperature management and stabilization. Decisions should not be made within the first hours based purely on the CPR duration or immediate exam. Prolonged CPR does not automatically exclude good outcomes. Many studies show meaningful neurologic recovery even after 30-40 minutes of CPR, especially in witnessed arrest, shockable rhythms, younger patients, cardiac cause arrests, particularly STEMI, and high-quality in-hospital resuscitation. Early PCI improves survival in post-arrest STEMI. This is one of the strongest evidence-based interventions for improving survival with good neurological outcome. So, was the decision correct? From a guideline-based perspective, the answer is no. The presence of STEMI after ROSC is a clear indication for emergent coronary angiography and primary PCI, irrespective of prolonged CPR. The patient met nearly all criteria favoring intervention: young age, witnessed arrest, shockable rhythm, ROSC achieved, ST elevation MI on ECG, hemodynamically stable in the ICU, withholding angiography primarily because CPR lasted greater than 30 minutes is not supported by current guidelines. This does not imply poor judgment or blame. It simply highlights how challenging real-time decisions can be, especially under uncertainty. It also underscores the importance of being aware of evolving guidelines in post-arrest care. This case reminds us that decisions made in the first minutes to hours after cardiac arrest carry enormous weight. Guidelines consistently recommend immediate coronary angiography for any patient with ROSC and ST segment elevation, regardless of CPR duration. While outcomes may still be poor, as in this patient, the role of the clinician is to follow the best supported evidence to give the patient every possible chance of survival and neurological recovery. Understanding and applying these guidelines is essential for all clinicians involved in cardiac arrest and post-arrest care.